And it's my pleasure today to present you the surgical treatment of pseudo-exfoliative glaucoma, which is a very common disease in Switzerland, but I know that you also have it in India, and that's why the subject might be of interest. Okay, this is, I mean, typically what we can see in an eye with, pseudo-exfoliation. There is not always glaucoma because you can have pseudo-exfoliation without glaucoma, but often it's followed by glaucoma because those little particles are actually blocking the drainage of aqueous outflow at the level of the trabeculum. We have different images on the zonula here. In the anterior chamber, these are very heavy pseudo-exfoliation on the lens here. And this is the angle where you can see, I mean, if you are very careful, you can see all those little deposits of pseudo-exfoliation in the angle at the level of the trabeculum. And what you can also see often is the excess of pigmentation, which gives this typical Sanpolesi line at the level of the Schwalb's line here. And can also see it down here on the down pictures. I don't know if you see my arrow, but I'm showing you with my little arrow of the computer. So this is at the angle. Often the angle is open, but of course in India, where the angles are mostly closed, you might also see pseudo-exfoliation in closed angle glaucoma. What is the algorithm of medical and surgical treatment of pseudo-exfoliation glaucoma? Of course, we always start with medical therapy. That's the easiest and the less traumatic, if I can say. We usually give beta blockers, but also prostaglandin and all the other drugs we have. Laser trabecular plasty can be proposed as a good treatment because that may kind of clean a little bit the angle and allows a better outflow through the trabeculum. But it can be also dangerous because in some patients, as with pigmentary glaucoma, when you treat with the trabeculum with the laser, it can induce a spike in the IOP. I've had a few cases where I had to operate rapidly after the laser because the pressure went up to 50 or even more. When you have to operate because the medical therapy is not sufficient, we can do regular trabeculectomy or deep sclerectomy or viscocanostomy. I mean, all those filtering surgeries are very good and very efficient in pseudo-exfoliative glaucoma. And like in any glaucoma, if there is a failure of regular filtering surgery, you can put a tube or at the end do a cycloablation, but that is not the subject of my talk. I just want to give you a few information on surgical treatment before talking about Gonio wash, which is the latest technology we are using in this particular diagnosis. So trabeculectomy is very efficient and has basically the same results as in primary open-angle glaucoma. There is a special care to be given to those patients because they have a tendency to have more post-op inflammation because there is a rupture of the blood aqueous barrier in pseudo-exfoliation. So you have to be careful. They have more inflammation and they may actually scar more rapidly due to that if you don't give enough anti-inflammatory treatment. Usually we give steroids the first months and then we switch to non-steroidal anti-inflammatory drugs for the next 2 months. So total usually 3 months, 4 months if a patient is young and there's a lot of inflammation. I want just to give you a few words on deep sclerectomy because this is my baby since almost 30 years. The advantage is something like you don't need to open the anterior chamber, so you really reduce the amount of post-op inflammation, and especially for pseudo-exfoliation, it works very well. For those who don't know deep sclerectomy, we are actually creating a filtering bleb inside the sclera and not only under the conjunctiva. So you can see, like on the right picture on the right side, there is almost no bleb, but the pressure is controlled because the bleb is inside the sclera. And this is very interesting for many patients, especially for the young, especially for even the conjunctival glaucoma, because you're not counting on the subconjunctival bleb. On the picture left and down here, you can see that the D is the membrane we are leaving in place, which is called the trabecular Descemet's membrane. The water will flow through and then go into the B space, which is the intrascleral bleb. From there, the aqueous can be drained in the subconjunctival bleb under A, or can also go through the subchoroidal space under C, where some part of the aqueous can be drained. So we have three ways of aqueous outflow. Now, if you have a patient who doesn't come often for follow-up, sometimes, we have to do a goniopuncture with a laser is to perforate the membrane D here on the skin, because this membrane with time gets a little bit thicker and the flow through the membrane is less good. And then we do a laser. But in places, and I'm operating a lot in India, I'm operating a lot in Africa, in those places, in the countryside mainly, patient may not come for follow-up. Then deep sclerectomy is not a good proposition. What I do in those cases, I still do my deep sclerectomy dissection, but I'm opening the membrane and then I'm closing my superficial flap very tightly so that I have a good resistance for the aqueous outflow, and so I can avoid post-op hypertony. So the opening of the membrane during the surgery is called penetrating deep sclerectomy, and this is an excellent technique for patients who are not coming easily for follow-up. It's just a scheme of the deep sclerectomy. Here we were using a collagen implant to keep that space open. Today we don't have any more the collagen, but we are using a substance called Elaflow, which is a high-density hyaluronic acid. It's a reticulated hyaluronic acid, and this will stay in the space for about 3 months. So it will allow the space to be created and to sustain. Just a few results. Deep sclerectomy, we started in 1994, so it's almost 28 years. This was a study we did with a mean pressure of 27 preoperatively. You can see that after 12 years, the pressure was 11. So good IOP control with the technique if you do goniopuncture when it's needed. If you do a penetrating deep sclerectomy, it's even a lower pressure. We are below 10 millimeters of mercury because there is really no resistance at the level of the membrane. And after 28 years and more than 15,000 surgeries, we are very happy with the technique. I'm still continuing because in my hands, this gives us the best results with very little complications and allows to operate early cases because we know we have a robust and safe technique. And even we can also operate very, very late stages. Sometimes we are afraid to operate patients with very advanced glaucoma, but doing deep sclerectomy, you don't take so much risk, so you can do it. Last week I was in Africa. I did about 35 surgeries on very advanced glaucoma, only eyes with like hand movement vision. And the patients who were coming, people had to bring them. They could not walk alone. And interestingly, a few patients could come alone the next day because they could see again. The pressure coming down from 50 to 10 allowed the optic nerve to be able to work a little bit better, and they could see again something. So I think it works to operate even in those very advanced cases, and pseudo exfoliation is the same as any other glaucoma. So to come back with a pseudo exfoliation, even if we get those material in front of the trabeculum, interestingly, by leaving the membrane is still okay because there is enough flow to regulate the pressure. The goniopuncture, of course, is very important because, as I said, the membrane with time will become thicker. And you can see that's the lens I'm using to do the goniopuncture with my YAG laser. I use usually 3 millijoule or more. And then we are creating a hole inside the membrane here. Just a few numbers. We did a first study a long time ago. Dr. Mendrinos Mansouri and Sharawi that some people know. We took 22 eyes with a mean follow-up of almost 4 years. And the result was that the pressure before was almost 30. In Switzerland, our mean pressure before surgery for primary open-angle glaucoma is usually 23, 25. Now we are a bit higher, almost 5 millimeters more, because pseudo exfoliation gives you higher pressure than ordinary open-angle glaucoma. And interestingly, the post-op was 13.2, which is slightly more than the primary open, where we get about 11, 12, but still it's a good pressure, and I'm feeling very happy with this post-op pressure. The complete success, meaning with no therapy, was 54%, and with or without therapy was 90%. The Goniopuncture was done in 63%, so it's not all the patients, but most of the patients need a Goniopuncture with the laser after surgery. This is another study done in Finland, where they took 68 patients with a mean pressure of 23, and it came down to 11. So that shows really that in pseudo exfoliation, you can do a deep sclerectomy, even if you leave the membrane, gives you a good result with the laser Goniopuncture. In their study, the Finnish colleagues did the laser in 87%, which is almost all the patient got Goniopuncture. This was interesting. The guy on the picture here in the center next to me, I'm here, became a professor due to that study. That was his main work on pseudo exfoliation a few years ago, and that I think is 4 years ago, when we were in Helsinki having the big feast for his promotion. See, the Finnish are very classic, and they like to wear fantastic shoes, even with the hat. Every surgery has a specific hat. This is the ophthalmology hat, and then the other surgeons have a different color of hats. Now, that's another study with Dr. Wishart in England, who has been doing mainly viscocannalostomy. And here we can see that it's not as successful as with deep sclerectomy. The mean IOP reduction was 30% without Goniopuncture. And then the success rate was 0% when there was no Goniopuncture. That just shows that the Goniopuncture is very important. Or if you don't have access to Goniopuncture because you don't have a laser, or because patients are not coming back for it, then just open the membrane during surgery. And success rate when the YAG was done was 92%, which is a good success also with viscocannalostomy. Now I'm coming to less invasive techniques, and this was done a long time ago, in 93, 94. Dr. Jacobi in Germany already was talking about trabecular aspiration. He had a little tool like the Gonio aspiration, what we do at the end of the cataract surgery with the phaco. He was aspirating those little particles of pseudo exfoliation. He published the result in 1998, so 4 years later. And the results were good in short term, but somehow disappointing with a longer follow-up. And that's why this technique was never really continued, either in Germany or anywhere else. But then later, in the beginning of the year 2000, one of my colleagues, Dr. Tran, in our clinic, had the idea not to aspirate those particles, but just to wash them out. And he created a special cannula, which is today called the Tran cannula. Tran is his name. He's from actually Vietnam, and then he came as a refugee 30 years ago in Switzerland. He's a very good ophthalmologist and developed this technology. And I'm going to show you a little bit how it functions and what is the principle. So during surgery, this is a video, yeah. So we have this special cannula which gives a straight jet, like a chain. And this will actually be able to, with some pressure, we are increasing the pressure in the phaco machine to go up to 80. And then we're entering one of the ports and then we are washing, we are standing parallel to the iris plane and stopping at about 1 millimeter, 2 millimeters from the trabeculum, so the angle. And then we are washing, going around the 360 degree of the angle to try to really wash away all those particles. When we are working on the main entry, we don't need to have an aspiration because there is enough water coming out through the main entry. So just one cannula can be used. But if you work on the second small entry, it's better to aspirate on the other side. Otherwise, you don't get a good washout. So this is what we do. And we do that at the end of cataract surgery. Usually those glaucoma are not very advanced, because if they are advanced, I prefer to do a deep sclerectomy. But if we have early glaucoma, but patient having quite heavy treatment already, usually 2 or 3 drops to maintain the good pressure, then this is a very good technique, because you'll see the results. We can reduce the number of medication for many, many years. These are interesting pictures. On the top here, you have your UBM showing some debris in the angle. You can see the picture here with the debris. And then after surgery, all those little debris have been washed out. You can see it also on the picture here. There was a bit of whitish color on the top picture of the trabeculum, and then down the trabeculum has been cleaned. These are the first results we had in the first 35 eyes in 28 patients operated between 2007 and 2010. And the mean pressure before was 18, and it came down not so much, 17 and then 16 after 6 months. What was interesting was that the mean number of medication was reduced from 2.2 medication per eyes to 0.6. So basically 2 to half of medication, meaning that half of the patient could live without treatment and half at 1 treatment. There was no complication observed in this type of surgery. Actually, having done many, many more, we have some kind of complications sometimes, such as IOP spike in the first 24 hours, because we have been washing the trabeculum, we have been creating some probably trabeculitis, a little bit of inflammation due to mechanical inflammation. And so what I do now, systematically, I give to the patient Diamox right after surgery, 6 hours later and 12 hours later. And that actually reduces the risk of this IOP spike after the surgery. But that's the only complication we had to mention after this technique. Bigger study was done later between 2007 and 2015. We did a retrospective analysis with an 8-year post-op period. 122 patients were studied and 190 eyes were enrolled. They were always we did cataract with pseudo exfoliation patient, and then we did the washing. The average age was 73, which is probably much more than in India, but these are the Swiss numbers. And we just do a routine phaco emulsification, IOL implantation, and then at the end, just before going away, we stay another 2 to 3 minutes washing the trabeculum with that Tran cannula. There were 2 surgeons, myself and Dr. Tran. We did basically the same number of patients. My patients were at a little bit higher pressure because I'm getting usually the difficult case to my clinic, being a glaucoma specialist, whereas Dr. Tran is a general ophthalmologist and gets probably easier cases. So that's why the pressure was slightly lower. But then the post-op pressure was 17 in my series compared to 15 in his series, which shows the same amount of IOP drop with both surgeons. The visual acuity was, of course, increased because the patient had cataract before and were operated and lens was removed. And so you can see that the mean visual was 0.6 before and almost 1.0 and stable during the 8 post-operative years. This is the pressure, including all the patients. So it came from 25 before surgery to about 16 with a slow increase with time. Here, after 6 years, the pressure went up to 18. That is, but the numbers are not so big here. But interestingly, you can see that even by doing a washing of the trabeculum 5 or 6 years later, you still have a good effect. And you see that the patients were not using drops, and that was the main advantage of it. This is the comparison between the two surgeons. As you can see that there is no difference in terms of efficacy. Having the same technique, it's actually quite obvious that we don't have a difference between surgeons. And this is the interesting slide, shows the decrease in medication. Before surgery, in this bigger series, patients were using 1.5 medication before surgery, which is 1.5 drop, and after surgery, 0.38, which is very little. That means just one patient out of 3 was using drops, 1 drop in the 8 years period after the surgery. So to conclude, if you have a pseudo exfoliation and if the glaucoma is very advanced, I will still propose to go for a regular trabeculectomy or deep sclerectomy. This is most efficient if you have a very capped disc, and if you want a very low pressure like 10 to 12, you need to do filtering surgery. But if you have a not very advanced glaucoma, but a patient has a cataract, is using medication for the ocular hypertension, even if the optic nerve is capped up to, I would say, 0.7, 0.8, which is not actually that bad in the life of a glaucomatous patient, then I think you can give the chance to just wash the trabeculum and have a pressure of about 15 postoperatively, and the advantage to be able to reduce dramatically the number of medication. So it increases the visual acuity because it's a combined surgery. It reduces the IOP and reduces the anti-glaucoma treatment. It's very simple, as you saw on the, I mean, you can still see on the video here. It's not difficult to do. It's rapid. It takes 2 to 3 minutes. It's very efficient. There is no complication except the risk of IOP spike in the first 24 hours, but can be treated with Diamox. There is no recurrence in our long-term study, at least for 8 years. I must say that now we have more than 15 years of experience with this technique. We had a few cases which we operated in the follow-up years. So we call it now NIGS, which is not a mix. You know, now people are picking up minimally invasive glaucoma surgery, but this is nano, and it's even less than minimally invasive. It's really no invasive and gives you very good results in specific patients. And this is just an example. You can see the pseudo exfoliation in 2007, pressure was 33. 3 years later, pressure was 18, very clean eye. And 7 years later, in 14, still clean eye, no pseudo exfoliation, pressure of 20. Since the optic nerve was not so much capped, we could keep just to observe this patient for another time. And this shows you the cannula, which has been now produced by a little company in Switzerland called Fabrinal. And this is available everywhere. It's not expensive and it allows you to really reduce the treatment of your pseudo-exfoliative patients with glaucoma. Future treatment in pseudo-exfoliation might be to find, some therapy where we can actually stop the production of the pseudo-exfoliation in the eye, such as depolarizing the pseudo-exfoliation material also. But this is not yet on the market, but we're still working on this new technology, not in my lab, but in other places. So that is the end of my talk. I thank you very much for your attention. And I'm staying a little while if you have any questions to try to answer to them. So thank you very much.
Thank you, Dr. Mermoud. That was a wonderful presentation. I really like your term NIGS. It doesn't add much to a cataract surgery which the patient is anyway going through, and well and good if we can reduce medicines, we're actually making the patient comfortable. Dr. Kamla, Savita, any questions to ask, please go ahead.
Yes, I have a question to Dr. Mermoud. Can we use a normal cannula if we don't have the recommended cannula? and keep our phaco settings at 80, will that help? Because you have your cannula which has a jet at 30 degrees angulated, which washes your angles. So is it worth it to try with the normal usual aspiration cannula? Can we do that? Will that give us similar results?
Yes, thank you for your question. It's a very good question. I don't have experience because we never tried, because I was lucky to have the Tran cannula from the beginning, because Dr. Tran came to me and said, why don't you, Andre, try my cannula? And so I tried it, and I was very, I was very happy with it. Now I'm always using it, but I think it's worth, it would be very interesting to do a comparison study using just the regular infusion cannula that you are using in the phaco to see if you can get also some results. And I'm challenging you to try to do that study because I'm sure it can. That's a very good question, but I don't have the answer, unfortunately. I never tried.
Thank you for a very lucid talk, sir. Thank you so much.
Dr. Mer?
I have a question to Dr. Mermoud. Can I, sir?
Sure.
What we are seeing is that the pseudo exfoliation is a very continuous process, because even after 4 or 5 years after the surgery, the classic that bull's eye sign and everything, it is seen on the the posterior capsule on the lens also. In the many times after 3-4 years when we see the patient, the bullseye appearance is seen on the pseudophacos also. So it's a continuous process which is going on, and that is what has been the classical teaching also so far. So how do you explain that and this Gonio wash? According to your study, you are saying that up till 8 years, there was absolutely no change. Have you seen any cases like this?
Yes, you're totally right. The pseudo-exfoliation principle or disease is not stopping after your washout. The disease will continue, and we can see pseudo-exfoliation in the angle or on the lens after cataract surgery. That is totally correct. But that was our experience. That probably the process is very slow, and so there is still creation of pseudo-exfoliation material. There is still deposition of this material on different part of the anterior segment, but at least for 8 years, we were able to maintain it. And then you could imagine to actually rewash, because washing is very simple to do. Now, Dr. Tran has done it actually. He has just taken the patient back to the theater, and he has done 2 paracenteses and has been washing the trabeculum again with success. So myself, I didn't need to do it. Usually I'm treating more advanced glaucoma on my clinic, so that usually when I have to do something, I'll do a deep sclerectomy as a second procedure. But Dr. Tran has even done, use this technique in primary cases without doing cataract surgery, having just pseudo-exfoliation, early glaucoma with 2 medication, was proposing the Tran cannula washout, and it worked very well for him.
Okay. How frequently do you recommend a rewash, sir?
Sorry, can you repeat?
How frequently do you recommend rewashing the...
Well, I would wait for the patient to have his pressure going back up and above the target pressure. See if you have an early glaucoma with a CD ratio of 0.6, still a quite good visual field. And then your aim pressure, let's say, is 18. If the pressure goes again to 25, then first you put maybe a medication. And if that medication is not any more successful, then I would go for a second washout.
Okay.
Thank you, Doctor.
Thank you, sir.
Thank you, Dr. Mermoud. We are actually